Hey everybody, I'm really excited to be here. I'm Dana Donofree. I'm the CEO and founder of Ana Ono Intimates, and we make mastectomy and recovery garments for those that are facing their surgeries, often related to a breast cancer diagnosis or an effort to avoid one. And I'm here with an incredible physician and doctor who is also a friend of mine, an advisor, a mentor. I know that he's incredibly passionate about what he does. And believe it or not, he actually trained my plastic surgeon that did my mastectomy and breast reconstruction, Dr. Brannon Claytor. Dr. Claytor is the chief of plastic surgery at Main Line Heath and the owner of his own private practice, Noone Plastic Surgery. And if that wasn't enough, Claytor is also the plastic surgeon on the breast cancer team as an educator to the breast surgery oncology fellows in training at Bryn Mawr Hospital, all here in the backyard of Philadelphia. So Dr. Claytor, I can't tell you how incredibly honored I am that we get to have this conversation together about some of the newest evolvements from COVID-19 and how that's going to continue to affect us breast cancer patients and your patients. So before we dive into the incredible questions that patients have sent us just in the last 24 hours since this news broke, tell us a little bit about you.
Dana, thanks so much. I'm humbled and very grateful that you reached out and that I'm able to share some of this information with your friends and this community. So I am a plastic surgeon in the community in the suburbs of Philadelphia and have been chief of plastic surgery here for approximately 3 years and get to work very closely with training the oncology fellows, breast oncology fellows, as they go through their training program. One of the reasons that I think it's so significant to have a conversation with patients who are facing a new breast cancer diagnosis right now is that due to this virus, COVID-19, it has become increasingly concerning about having the resources available to be able to operate. We stopped doing all elective cases approximately 2 weeks ago. And in that period of time, we have seen a nearly logarithmic increase in the number of cases that are diagnosed in the last 2 weeks. And it's an alarming trend, which is starting to get all of the healthcare professionals to ask hard questions about what procedures are considered essential and which procedures are considered ones that can be put off for a period of time. And we have all worked very hard over the last several decades to come up with the optimal treatment algorithms for patients who are going through their cancer treatment and then their reconstructive treatment. And thanks to the Women's Healthcare Act of 1998, this is, thank goodness, an essential part of their care. And while we hold it to an aesthetic standard, it's considered a necessary medical procedure. And obviously, it goes not only for the breast that's affected, but also for the contralateral breast and really any revisions that the patient and the plastic surgeon deem appropriate over patient's lifetime. And this is tremendous. However, as we enter into this uncharted territory of this virus, which is compromising hospitals' ability to provide essential services, we're starting to look and be asked to look at what procedures can be deferred. And so the reason this is so significant is our society, the American Society of Plastic Surgery, came out with some recommendations 2 days ago, which really has prompted our conversations and my conversations back with the hospital as we try and find a resolution forward that provides an opportunity to protect the resources that we have so that the essential procedures can be performed on the cancer side of breast cancer. And so these recommendations have come out and said basically, if these procedures can be delayed, if the reconstructive procedures can be delayed, it is something to be seriously considered. And so in the near future, meaning the immediate future, the next several days or even a week or two, a lot of patients who have already been scheduled are continuing along with those procedures. But going beyond that period of time, it appears that there are many avenues that can be explored, not only by the breast surgeons, but also by the breast reconstructive surgeons. So the oncologists are even starting to look at different scenarios and, can a mastectomy be downstaged to a lumpectomy? Can a lumpectomy be treated with just a medical treatment? Can the patient be given different medications to downstage them or delay their need for their surgery? And a lot of these recommendations are coming from the surgical oncologists are even looking at and making certain recommendations for the breast oncologists to be able to change the type of surgery, going from a mastectomy down to a lumpectomy, or even from a lumpectomy to putting the patient on medical management until this tsunami of the virus passes us by and we're able to get back to realigning our priorities so that we can make sure that these patients can come to the hospital and be treated safely.
I think we've actually pulled some really amazing questions from our community asking these questions. So I'm going to dive into some of what our community's been asking, and we're going to try to get through all of these in a short amount of time, but don't worry. If you have other questions that we didn't ask here and you didn't get answers, please leave them in the comments below. This is not the only chat that Claytor and I will have, so if we didn't cover something, please be sure to ask, because we will be tuning in every day if we need to answer these questions. So I think a good one to start out with here is there a difference with the reconstructive surgeries that are being performed in surgery centers versus hospitals?
That's an excellent question, and I would say no. And basically, whatever the policies are at our major hospitals should be the same policies at the surgery centers. And so if you were going to have it at a surgery center, you should anticipate the same level of care that you would be receiving at a hospital.
So in other words, this is maybe a staffing limitation. This is access to the equipment that's needed, and this stress is being panned through all centers. I mean, granted, we're here on the East Coast. We're feeling the heat of the pandemic much sooner than people in the center of the country are feeling it. So we're having this conversation now. Other centers are probably due to have it in a week or 2 weeks, just as this continues to spread.
If you can believe and follow along with this trend, it seems to be following almost a logarithmic trend. And so the concern obviously is that the resources to be able to care for patients who need ventilators and intensive care nursing, those resources may be moved from operating room nurses and doctors to assist in the ICUs. And so obviously a patient who undergoes surgery is intubated and consuming and using a ventilator. And so perhaps that ventilator could be utilized to help with life-saving support for a person who is afflicted by this. And so unfortunately, we just don't know what the demand is going to be. And so the caveat is to be prepared, and to further operate on patients could potentially lead to situations where we have expected scenarios where there may be postoperative complications, where you may need to go back to the hospital, you may need to be reoperated on. And while those are a rarity, it would certainly feel like an unfortunate scenario that may potentially have been avoided if that procedure hadn't been undertaken in the first place. And so
Right.
That's what it's really boils down to, is if anything can be delayed, to be thoughtful about it and to ask the question of yourself as well as your care provider, can this be delayed?
Well, and I think that the obvious is that there's a containment issue as well, right? You could contract COVID-19 while you're in that hospital, in the waiting room, wherever you are, and obviously you're compromised because you're healing from your surgery. And I think, that's the most obvious piece, the ventilators being the other huge piece of it. So any idea, I think there's a lot of questions of people that are have either already had their mastectomies or are in sort of the process. Is there a time limitation here? Do we think there's any recommendations of when this might be lifted?
Wow, I don't.
No.
I wouldn't be able to estimate that. I think that we are all waiting for the flattening of the curve to see a diminishment of this, hoping that we have a development of herd immunity and all these different terms that translate into this becoming a less infectious and less widespread viral disease. And until we have a better handle on that, it would be premature to provide any estimates.
What would be your advice to patients to say, how are they supposed to kind of stay in the know and follow up with their plastic surgeon? Or, what advice can you give to them as running the practice where you're kind of trying to field all of this right now? Like, how often should they be checking in with you guys to determine, are we ready yet? Are we ready yet? Are we ready yet?
Well, one of the things that has come about is basically the advent of telehealth, and virtually every practice is utilizing some form of telehealth today that they may not have been even as recently as 2 weeks ago. So it's a tremendously efficient way to reach out and have that face-to-face contact where you can really read people's emotions much better than you can just talking to somebody on the phone or through an email. And it's a much more intimate conversation that you can have. And hopefully that provides an avenue so that sort of dialogue can happen. But there are different patients, obviously. There are post-op patients that we continue to see back if it's an urgent issue, sutures to be removed and so forth. But we're rapidly transitioning even those post-op patients to telehealth. And so moving forward prospectively, that's a way to stay in communication that provides an intimate communication that we haven't had before.
All right, so these questions have been amazing so far. And of course, we run out of time here on Instagram TV all the time. So please tune in to our second part of the series coming right behind it. Thanks so much. Hey, welcome back. Thank you for joining us. If you haven't tuned into part one, please watch part one first because we've got incredible questions. But rejoining me is Dr. Brannon Claytor. He's got incredible background and experience, also just discussed earlier, but really another huge connecting piece to us is that we're both deeply involved with Living Beyond Breast Cancer, and Dr. Claytor and his incredible wife, Sarah, were co-chairs to our LBBC Gala last year, and knowing that he's here truly for our patient care and attention is really something miraculous. So, Claytor, what do you think about that?
I consider it an enormous honor that I was able to participate in Living Beyond Breast Cancer's Butterfly Ball last year with all of the other co-chairs. And my wife and I had a wonderful experience participating and being part of this tremendous organization. And so I think that, as Gene Sachs always says, this organization's main objective is to provide trusted, vetted information so that patients can use that to make their best decisions. And so I think that that's what you and I are trying to do here, provide this kind of information for patients as they are trying to make decisions in this chaotic time.
An important part of that is also lbbc.org. Please go there, Living Beyond Breast Cancer. We are posting daily updates. If you're stage 4 metastatic, if you're looking at surgery decisions, if you have, if your white blood cell counts are down, we have all of that information online. So please go check out lbbc.org. So I think that these are some really quick answers that we can get through fairly fast before we kind of finish on a banger. But how long is it okay to have your expanders in?
Um, Almost indefinitely. So there's no time period where you say, oh my gosh, I need to have them out at this stage. There's no downside to having that be an extended period of time.
And when you say delayed reconstruction, because I think, from what I would really like to encourage people is that waiting on your reconstruction is absolutely okay. It's 100% okay to wait. You're not taking on any additional risk. Once that cancer's been removed from your body, you can come back in 6 months, 12 months, 18 months, whatever you feel right is right for you. So, but what is delayed reconstruction? So if they have expanders, that's okay. If they go DTI, that's okay. What kind of patients are we talking about that might have a delayed reconstruction?
So let's break it down into two main groups. One is autogenous reconstruction, where you're using some of your own body tissue,
The
and
flap
then
surgeries.
the flap surgeries. And then the other one is any kind of expander or implant-based reconstruction. So for a autogenous tissue, a lot of times we're using the abdomen or the area right around your belly button, and that can either be brought up as a pedicled tissue or a tram, or a free tissue, which is the deep flap. And so there are surgeons today who actually encourage a delayed treatment of this right from the get-go. And so obviously that's a very accepted and reasonable treatment algorithm that would allow for the mastectomy to be performed, let the wounds heal, and then come back at a staged time to do the autogenous flap procedure. And so while it's obviously advantageous to have it happen immediately, those opportunities exist down the road at any time point. It gets a little bit more complicated if the patient needs radiation, but again, that's a higher level risk, and therefore being done because the patient has more advanced disease and many other comorbidities. And so that needs to be taken into consideration. If you're talking about an implant-based reconstruction, so one of the advantages of direct to implant is utilizing the breast envelope and being able to put the implant in and utilize that entire envelope at that time, as opposed to an expander where you are obviously growing that tissue and expanding out that tissue. So there will be differences and challenges between opportunities for direct implant versus tissue expander, but recognizing that those opportunities for implant-based reconstruction will still be available down the road, albeit with maybe some potential additional procedures that would need to be performed. And so as it stands currently, based on the guidelines that are coming out from the American Society of Plastic Surgery, since flap surgeries tend to have a longer hospital stay afterwards, they're being discouraged at this time moving forward. Implant or direct implant or expander operations are really being asked to be examined on a case-by-case basis based on the patient's multiple medical histories and where they are, their comorbidities, local resources. And so for the time being, all plastic surgeons are being asked to think, be thoughtful about what procedures you're moving forward with your patients, as well as the patient's understanding of the overall risk that may be involved in undergoing a extra procedure at this time versus limiting it to either just a lumpectomy or just a mastectomy alone, and then coming back at a later time for that delayed reconstruction. And again, these are operations that have been done in the past. This is not a new concept to come back and do a delayed reconstruction. So don't feel that this is a novel concept. It's not. The challenge, of course, is we have made such progress, and there's so many great innovations in immediate reconstruction, which are valuable, that I think, to put it in the perspective of the risks involved, need to be thought of in a thoughtful, prospective manner, and weighing all the pluses and the minuses, and the risks and benefits, because full reconstruction can happen down the road. And in this time of limited resources and potential increased contamination or risk of infection from COVID virus, with increased proximity to the hospital, it may be prudent to delay these reconstructions until this tsunami passes.
So what surgeries are being deemed essential at this point? I think a really important question was, somebody's been diagnosed with TNBC,
Right.
so triple negative breast cancer. Is the aggressiveness of your cancer, I'm sure, obviously being considered? I know for myself, my grade was off the charts. My metabolic rate was off the charts. My tumor was doubling in size after every test. If my surgeon called me and told me I had to get a lumpectomy instead of a mastectomy, I would be freaking out. I don't even know what I would be thinking, from my mind, not the physicians and the science mind, but just from the decision point.
Absolutely. And so my role as the plastic surgeon is to follow the lead of the breast oncologist. And the breast surgical oncologists are very aware of the patients who need surgery versus the patients who can be staged or downgraded from a mastectomy to a lumpectomy. And really, the take home from this exchange should be to call your breast oncology surgeon and have that conversation with them and say, where am I in this? In that, what is the best time to be able to intervene to help reduce my risk of any kind of potential concomitant disease process, such as this as COVID virus, versus my risk on my oncology stage and where I am on my cancer. And so I've had many conversations with the breast surgeons, and they are very comfortable having these conversations. They are well versed on this. They have a great understanding about what's imperative and what can be staged. So that's the first place to start.
That's great advice and great insight. And I think what we really need to take away from this is that this is being done to keep everybody's best interests at hand. And it's going to be scary for a lot of these women that have to face, the mastectomy surgery side and not have the reconstruction that they were committed to or really, locking arms with. It might also, help some individuals really embrace being flat. I think that there's a lot of opportunity here, and the biggest issue is that it doesn't stop a decision that you made. It just delays it.
Correct.
And you can have just as great results later as you can have today at your surgery site.
I think that all of the immediate burdens on the healthcare system need to be looked at and use those as metrics for the risks and benefits as you're moving forward, and recognize that absolutely some of our great advances in immediate reconstruction are just that. They are fantastic. And that putting this in perspective and looking at the benefits of the surgical procedures to achieve cancer-free diagnosis, and then moving towards the desired aesthetic and wholeness of reconstruction at a time when the resources are really available to be able to deliver that, in the most optimal way.
Any advice, this might seem petty, but this is going to be of interest for the patient. Any advice on them for scheduling purposes? Because just as we see events are getting rescheduled, right? Some people already have their mastectomy scheduled for the July, August, September, October period.
Yeah.
Do you predict a conflict with all of these that are getting delayed, how they're going to get sliced in, or do you feel like there's enough time that people can still get the treatment that they want in a shorter amount of time?
I think that that's showing a lot of insight into this scenario, and it may be beneficial at this time to communicate with your breast surgeon to say, I understand that right now is not optimal. Can we pick a time in the future? And I think that does a lot of good things. I think it helps psychologically say, I have my time period, number one. And number two, it helps create a window for that patient so that as the patients who are being redeployed and pushed back at a different time, obviously the more urgent ones will be taken care of, in a timely fashion, but it creates a set standard of expectations, because I'm sure that as things ramp back up again, those resources will be put into place. And to have that schedule set must be tremendous in terms of peace of mind and planning. But at the same time, obviously, I think we all need to be understanding of greater need for resources across our entire health system.
So if I was your patient, I was sitting in your chair today and you told me you had to delay my reconstruction, give me one wise point of view, hopeful insight. What would you say to me that would just lift me off the ground and put me back out there and keep fighting?
That we would be working together to give you the best aesthetic result and the greatest opportunity for lifelong survival.
Awesome. This is incredible. I know there's going to be a lot more questions because we only touched on a few. Thank you for those that sent in questions. We really appreciate your engagement in this conversation. And if you have an up and coming surgery, please, again, add your questions down to the comments. If you need to find Dr. Claytor himself, he's at Claytor Plastic Surgery on Instagram. I'm sure that you can reach the office, ask questions, but we will be looking at the feed below, and we'll hop back online with him if we need to get more answers. So thank you guys so much. I know this is a tough time. We're all facing challenges, especially cancer patients. And just know that with Ana Ono, you're never alone. Thank you guys.